Okay, so now we're going to be starting the medical emergencies. So when you go into the real app and when we say it's all hyperlinked, when you get to the section, if you touch the different sections, it'll take you right to that section. So you wouldn't have to go through each section to find, say, dehydration. So let's start with allergic reactions. So we treat allergic reactions right now, so we'll just hit really the differences of how this one's set up. So we're actually going to change the language a little bit on this one, because right now it talks about moderate and severe, and the concern is that if you say moderate, do you think, well, the patient's not that serious? In both cases, the patient may be having respiratory issues, the tongue may be swelling, throat may be swelling. In either case, we're going to give our epinephrine. The decision really is what route. So what's going to determine that is the blood pressure. So we use the blood pressure of 100. How can I, without taking an actual blood pressure on the arm, determine whether someone has an adequate blood pressure or not to be able to use the IM route?
Pulse.
Exactly. Pulse, but more specifically, do they have a radial pulse? So if I'm talking to you, you know I'm alive. But if I don't have a radial pulse, but I have a carotid pulse, that's a great indication that my blood pressure is significantly low, probably 70 or 80, maybe up to 90. Will IM work? Probably not great. So a better route would be to go IV or IO in the humerus. So if we're going to go that route, again, we're using our push dose epi, so 1 ml every 30 seconds until we get that desired blood pressure effect. So when you look at this protocol, for a mild reaction, so just a little bit of rash, are we going to stick the patient with epi? No, just like we've always been doing. So depends on the symptoms. You take parts of the protocol that you think are appropriate, but don't worry about giving epinephrine. If you think they start complaining of airway issues and you're starting to think, maybe I should give them the epinephrine, give them the epinephrine. That is a life-saving drug, particularly in this case. All right, we clear on that? For the pediatric, same sort of idea. The difference between which route we're going to give the epinephrine would be the blood pressure again. So unless there's a specific question, I'm going to keep going. All right, altered mental. This screen is just an idea, a reminder of things to consider if you have a patient with altered mental status. The diabetes was one of those examples. So if you knew you had a patient, blood sugar was below 60, what are we giving them now? The D10. We've been carrying it for a little while. How are we giving it? Are we dripping it slowly in, or are we giving it fast? So the way to think about it is, you're going to be giving it 100 mLs at a time as fast as you can. You push your 100 mLs in, that should fix the hypoglycemia. Recheck the blood sugar. Push another 100 mLs if it didn't work, check the blood sugar. Chances are that has fixed the problem for sure. So the idea is not to drip it in slowly, it's to push that D10 in pretty quickly as you can for 100 mLs at a time. All right? When we talk about, okay, you had a patient, they were altered, they were unconscious, now we gave the D10 and now they're alert and oriented. And we've all faced the patient and said, look, I feel better, I don't want to go now. So what do? We discussed that earlier and talking about, well, can you force the patient, can you not? So just one thing to be aware of, if someone takes oral diabetes medications, they're at a much higher risk of going back into that hypoglycemia. So that patient you would absolutely want to take to the hospital. If they refuse and you've tried everything you reasonably could, you want to try to make sure and document that someone was in the house, they had food, they've been eating, and make sure that you're setting them up to not go back into hypoglycemia. The glucagon's still an option, IM. So we haven't been using it that much, but we're keeping it in for this case. And also you'll see for beta blocker overdose, it would be the appropriate treatment. For the pediatric, we're using the D10 as well, 5 milliliters per kilogram. And same idea, you're going to be pushing it in quickly retesting the sugar and repeating as needed. All right, dystonic reaction. So this patient probably is on psych medications. They have that reaction. They may have the face that's stuck in a certain position. We've treated this in the past and we've written it up more as an allergic reaction to the medication. All we did was make a new protocol to call it what it really was. So the treatment hasn't changed, the Benadryl, but it just explains it a little bit better than we had it. Okay, so fluid. The language on the fluid is going to be the same throughout the protocol now. So for the adult, 1 liter, recheck lung sounds every 500 mLs. For the pediatric, 20 mLs per key, can repeat twice. So it should be consistent throughout. If it's not, let us know and we'll make sure it's consistent. Okay, hyperkalemia. What is hyperkalemia? Travis, that's true. High potassium, perfect. So high potassium. What patient would be realistic that we would even know they had high potassium?
High T waves.
Right. So you could use the EKG and be a good indicator, but if you knew the person was a dialysis patient and either hadn't had it yet, missed an appointment, we even had a case where the person was unresponsive in front of the dialysis center. So that's a good indication that this is a possibility. So if someone's mildly hyperkalemic, you're going to start seeing those P waves, those spike T waves like Matt was talking about. When we really get concerned is when the QRS starts widening and the QT interval starts widening. That's when it becomes very dangerous. So as a general rule, if we knew they were hyperkalemic, we would start giving our treatment. So if you had to pick one drug, if I said, what's the treatment for hyperkalemia, what would it be? Calcium, exactly. So you have one, you can only get one IV at the time, and there's always that discussion, well, do I give the bicarb first, the calcium first? Think of it as calcium chloride is the treatment for it. That's what's stabilizing that cell, and everything else is a bonus. If you think of it like that, it makes it a little easier if you're faced with that. So we give the calcium chloride, and why am I giving the albuterol? Are they having bronchoconstriction? That's not why we're giving them. That's helping the potassium push back into the cell. So we give the albuterol, we give the bicarb to help the potassium go in. In the hospital, you may even see them giving dextrose and insulin, all helping the potassium push back into the cell. So in a later slide, we'll talk about, well, if you suspect that they're hyperkalemic, there's one drug we definitely wouldn't give them. Does anyone know what it is? All right, we'll keep you under suspense so you're excited for that slide. So we'll talk about that in a second. All right, so just remember that sine wave when we talk about that. So nausea, vomiting, we kept the language for the Zofran the same throughout. So you'll notice for the adult, we have 4 milligrams, and it's IM, IV, IO, and then we're keeping our ODT. So what is ODT? That's right, orally dissolving tablet. So we're keeping that. So if the person is able to take it orally, that ODT is still appropriate. You'll notice for the pediatrics, it says IMPO, but we also have ODT. That's actually a different route. So if they're over 4, you could consider giving ODT. But if they're younger, we don't want to give ODT, but this gives us the option to still give it PO. So just one example, but you have a 2-year-old. We're vomiting, you decide I want to give Zofran, the mom or dad says I don't want any IVs, and you're not giving them a shot. Well, ODT wouldn't be the option, wouldn't be the best choice because they're under 4. We could use PO. So what exactly does that mean? If you read down, we can use the IV formulation of Zofran, PO. So you would draw it up, but instead of giving it IV, we would squirt in the mouth, and it works as well. So it just gives us one more option out there. So respiratory distress, this is more of a general screen. It talks about conditions in general. Then it goes into specific conditions. So COPD, the patient's had a chronic condition, you would anticipate the high CO2 levels, maybe a lower SpO2 levels. In those patients, we'd be going with the albuterol and the Solu-Medrol. Those patients have the issue with their alveoli, and it's a chronic condition. We run a lot of asthma calls. So now we want to think of the asthma in two bundles. So the first bundle is the typical patient, the patient we're used to. So when you have asthma, you have the bronchoconstriction, the inflammation, increased mucus production. We're giving the albuterol for the bronchoconstriction, the Solu-Medrol for the inflammation. You notice there's no Atrovent anymore. So we've taken Atrovent out. It's a longer acting. We feel that the albuterol is great for our purpose, and there's no limit anymore. You can give it as needed. If this first bundle doesn't work, that's when we would go to our second bundle. So in the asthma and the COPD, you notice there's CPAP. So CPAP may help in both those cases. But if you're going to go that route or try that, make sure you're watching your patient. There is a chance the CPAP could make them worse. So if you did a trial of CPAP and they started getting worse, you would discontinue it, take it off them. So if the initial bundle didn't work, our other options would be Epi or MAG. So those have always been our options, and we discussed, well, which one is better. We put Epi before MAG for the simple reason it's quicker to give. So the MAG, how would we administer the MAG? Yeah, so you remember from page 10, we were putting the 2 grams in a 50 bag, running it 1 drop a second with a 10 drop set, and it takes 10 minutes versus giving the IM immediately. This could be another example where the 2 medics decide, you know what, for some reason I want to give the MAG before the Epi, it's acceptable. But we wrote it as try the Epi. If that doesn't work, you're going to repeat the Epi and give the MAG at the same time.
So these are written in sequential order then?
Yes, but again, if you feel for some reason you would rather give the MAG first and you can justify it, that might be a good example. So don't think of it as you have to always use the Epi first. Pediatrics, same idea. The first bundle is your usual patient. We would anticipate that'll fix most of them. If it doesn't, then we would go to our second bundle. Now we're getting into the croup. So if you have a patient, low-grade fever, they look sick, but not too sick, like more of a viral illness. They have a stridor, barky cough. Now we're describing a croup patient. We're going to give 0.3 of 1 to 1,000 epi, and we're going to give it nebulizer. So we even wrote, yes, 3 mLs, because people often question, that's a lot, but you're giving it through the nebulizer. You're not doing it through the IV. So that's a nebulized dose. We included epiglottitis into it now. So if you find a kid high fever, look very sick, they're tripoding, they're drooling, what does that patient possibly have? The epiglottitis. That can be very dangerous. So what is the key to know with epiglottitis? Exactly. So in that patient, our priority is to keep them calm. So if you're able to give the nebulized epi, do it. But don't risk agitating them. So our priority is keeping them calm and getting them to the emergency room. So even when that patient's in the emergency room, they're most likely going to go to the operating room before the doctor tries to intubate them. It can be that critical. So the worst thing we could do would be to try to examine the airway. And now we've closed the airway, and now we're trying to do a crike on the way to the hospital. So if you're ever considering those cases, just keep the patient calm and then just advise the staff of our suspicion when we arrive. So seizures. How do we treat seizures? What drug are we giving? So we're still giving Versed. When we look at the Versed dose through the protocol, it never changes. So whether you're giving it for seizure or sedation, for pacing or syncing, it's going to be the same across the board. So I gave my 5 milligrams, it didn't work. I repeated, I gave my other 5. I'm at my 10 milligram max. What would be my other option? The ketamine, exactly. So ketamine we're also using for seizures now. So make sure you realize that. Versed first, it doesn't work, our next option would be ketamine, and we should be successful with the ketamine. Yes?
You said the Versed dose is the same throughout. Is the ketamine dose the same throughout?
No, and you'll see, if we're using ketamine for excited delirium or some agitated person, we're gonna be giving it IM, but a higher dose. So yeah, that one unfortunately is different. Yes?
This morning, we actually had a seizure patient that was allergic to Versed, so can we bypass that and just go straight to the
Yes, so
ketamine?
that, I was gonna say, so there are circumstances, and one would be, exactly, they're allergic to the Versed, that's why we have that option. Great question. All right, any other questions? Good. Okay, sepsis. So this is the patient, we reasonably believe they have an infection. So normally we talk about they have a temperature, but technically the person could also be hypothermic. And we don't often think that, but that's true. So these are some of the ways you would reasonably think there was an infection. And now we come down, we know they're not pregnant, and now we're looking at our Q-SOFA criteria. So it's a little different criteria, but it's the same idea as our Sears criteria we used to use. We're using it as a predictor of who's a sepsis alert or in need of sepsis center. So if our patient has two of these three symptoms, so a hypotension, blood pressure less than 100, altered mental status, or tachypnea, so they're breathing fast. Why would a patient who's septic be breathing fast? What is their... Yeah, so that patient's in acidosis. So your body has a couple of different buffers to try to deal with the acidosis. The first being your respiratory. So you're going to start breathing a lot faster. When we start breathing faster, we blow off our CO2. So that's why we have in there. If your patient has a CO2 below 25, we're using that like the hospital uses lactates. So when you bring the patient into the hospital and you say, I think we have a sepsis alert, they're going to do some blood work, but they're going to do a lactate as soon as possible. If that's positive, meaning they're acidotic, they are now under that sepsis alert criteria, and that's when they very quickly do the blood cultures and they start the antibiotics. So we now know the sooner you get those antibiotics on board, the better the survival rate. So some systems are giving antibiotics in the field. We're not going to be doing that right now. Our key role is to identify these patients and get them to a hospital and call a sepsis alert. So we're using that CO2 as our lactate in the field, and we're finding there's a very high correlation between the two. So if your patient has two of those three, the keys for us is to give fluid, notify the hospital, and try to maintain that blood pressure. So we talk about saying, all right, a sepsis alert. Apparently at some of the hospitals, they still don't fully understand what that means. But once the staff realizes they have a sepsis patient, they follow very strict core measures. And that, so what we're advocating, keep calling a sepsis alert, because we think eventually hospitals are actually going to be designated as sepsis centers. So let's keep doing that, and sooner than later it'll have a standardized criteria for it. So I give my fluid. When we have hypotension, how do we treat it now? We try our fluid. The fluid doesn't work, I go to my push dose epi. So you'll see that's the answer consistently through the protocol. It's a lot easier now. Any questions on that? Okay. All right, stroke. So we've been using the RACE scale. Broward County, specifically our department, has been very successful using the RACE scale. So whether you knew it or not, what you were doing was you were predicting whether you had a large vessel occlusion. So the higher the number, the more likely it was. And we're very good at calling that. So the hospital's telling us, good job, now we want you to think about it a little bit differently. So we already said we're only going to comprehensive centers. But as of today, do I need a RACE score of 1 or more to call a stroke alert? Yes. As of today, correct, Travis, you do. What if I suddenly had slurred speech? No other symptoms. Would I technically be a 1 on this race score? Well, if you read here, slurred speech doesn't count, so no, I wouldn't be. But if you reasonably suspect it was brain central etiology, so you reasonably believe it has something to do with the brain, possibly could be a stroke, they want us calling a stroke alert. And more importantly, going to a comprehensive center. So there's a couple more examples where that might make sense. So you don't have to have a race score of 1. Travis has an example the other day where the only symptom the patient had was they couldn't swallow. And they said, call a stroke alert for that. So luckily, he went to the appropriate facility. So they're not saying we're not doing a good job. They're saying you're doing a great job. But we now want to make sure we don't miss any patient. So when they look at the admissions and the discharges, they try to identify all the cases that we missed, and not that we did anything wrong, but all the cases we missed that maybe could have been seen a little bit earlier. So that's what we're doing. Any questions on the stroke scale? It's still a 24-hour window, including wake-up strokes. This is numbers of the different interventionalists. A couple people were asking why FaceTime numbers. One of the Memorial docs, he actually has the crews FaceTime him with every patient, so he can actually see them. Our interventionalists are real happy with the way we're predicting and our accuracy, so we're not doing that right now, but that's a possibility in the future. So when we identify a stroke patient, we're going to the Comprehensive Stroke Center. We're going to still be transporting our patients at a 3rd-degree angle. And then if you notice, we're giving a fluid bolus. So not uncommon for stroke patients to have high blood pressure, 220 over 120. Why are we giving a fluid bolus? Correct, the circulation. So in the past, the patient had a high blood pressure. What was keeping the perfusion in the brain? That blood pressure. So we would lower the blood pressure thinking we were saving the patient, and we're actually making the stroke worse. What the patient's body was compensating, and particularly if you're older, you have collateral circulation in the brain. So what we're trying to do is we're giving a bolus, increasing the perfusion, hopefully creating an area that's survivable longer. So you remember when we talk about stroke, the penumbra, the area that's injury, if we can keep that viable, is the word they use, longer, we have a bigger window of success. So now when we bring these patients to the comprehensive stroke centers, a large proportion of them are actually walking out with no deficit at all. So the whole stroke procedure has drastically changed, even in the last 5 years. So this is one of the newer changes. So for some of us, it may seem a little weird, because in the past we'd actually considered lowering the pressure, but we're pretty sure this is going to have a huge increase of patients walking out with no deficit. Pediatric, we said less than 18. They're going to go to a comprehensive center, Broward Health, Joe DiMaggio. Same idea, you're going to give the bolus. All right, so that's the end of the medical section.